Hello, my name is Wahida Kent, and the title of my presentation is Who Supports the Families of Black and Minority Ethnic Children with Life-Limiting Conditions. The research I'll be presenting is my PhD research, which I undertook at Cardiff University and which was funded by Health and Care Research Wales. It was inspired by my 13 years of social work experience of managing a social care services supporting Black and minority ethnic carers of disabled children and children with life-limiting conditions. The research was driven by numerous discussions I had with health, education and social care practitioners who were concerned about the low take-up of formal support services from BME groups. And also there was anecdotal evidence of these families experiencing social isolation and access to poor support systems. There was a strong appetite amongst practitioners and academics to identify barriers to formal support, as well as shedding light on the caring experiences and support networks of this group of families, because this voice was very much missing in the academic discourse. So the background to this research: children with life-limiting conditions are a growing population and they face many challenges. It's key that we explore the issues they face and how best to support them and their families. There is increased prevalence of life-limiting conditions amongst some BME groups. Fraser et al. In 2012 showed in their research that prevalence per 10,000 is 27 for the white group, 48 for the South Asian group, so you can see the jump there, 42 in the Black group per 10,000, and 31 in the Chinese, mixed and other groups. So these differences are quite significant in terms of the rates of prevalence of life-limiting conditions amongst different minority ethnic groups. We also found that there's a dearth of research with the parent carers of Black and minority ethnic children with life-limiting conditions. Little is known about their experiences and their access to and take up of formal and informal support and the challenges they may face. The BME parent carer voice was missing from the academic discourse. What is their experience? Is there ethnic variance? The academic discourse contains opinions of academics and practitioners alone, and academics such as Featherstone and Broadhurst refer to the dangers of understanding research into help-seeking behaviours when the focus is on the perspective of professionals alone. Through interviews with both parent carers and practitioners, it was hoped that barriers to accessing support would be identified. The research provided an opportunity to explore the role of religion, culture and spirituality. Did this form a barrier to formal support? Did these institutions provide an additional layer of support? What role religion and religious institutions play in the lives of this group of families? How do professionals perceive the needs of BME families? Do they find working with them more challenging? What were some of the issues? How could these practitioners be supported? And finally, the aim was to shed light on very much the lived experience of this group of families, who are often referred to as invisible or hard to reach. So what is known about parent carers of children with life-limiting condition? A review of the literature demonstrates that some aspects of the experience of caring for a disabled child or child with life-limiting conditions are shared by parent carers irrespective of ethnicity. The range of issues experienced by this group of families are complex and wide-ranging and include the following: the negative impact of caring on parental physical and mental health. Financial impact. Disability and poverty have a complex and interdependent relationship. Families of disabled children can incur considerable additional expenditure on heating, housing, clothing, equipment, and other items. In the UK, disabled children experience higher levels of poverty and personal and social disadvantage than other children, and this has been proven in research done by Blackburn, Spencer and Reed in 2010. Providing basic necessities can be costly and place financial pressures on parents. Parents caring for a child with a life-limiting conditions have fewer opportunities to work. Despite the availability of disability benefits, the complexity of the system can result in challenges in accessing these. Fraser et al. In their 2012 research found the highest rates of prevalence of life-limiting conditions were amongst those living in the most deprived areas of England, which would suggest that there may be a link between poverty and disability. So social isolation and insufficient support is another recurring theme. Disabled children and their families face a high risk of social exclusion if they don't receive appropriate multi-agency support. Parent carers' health has been shown to improve as a result of support or respite, particularly during periods of high stress. This is well documented in research carried out by Cantwell, Muldoon and Gallagher in 2014. Without support from essential services, parents may feel they have little control over their situation, leading to feelings of loss of control, hopelessness, or despondency. So the impact of caring can go beyond the parent carers and impact on other immediate family relationships. Siblings in particular, due to the symbiotic nature of family life, inevitably caring for a child with life-limiting conditions will impact on other family members, particularly siblings in the household. The pressures and stresses of caring for a disabled child or child with life-limiting conditions is inevitably impacts on other members. So these were some of the themes that emerged from the academic literature. Delays in identification and diagnosis is also a recurring theme, one which also came up in my interviews with parent carers. Evidence suggests that carers from all sections of the community, and in particular carers from BME groups, often fail to access care services. So the methodology I adopted for my PhD research was mixed methods through qualitative in-depth interviews with 20 parent carers of BME children with life-limiting conditions and 10 practitioners working with such families. I was able to explore how ethnicity, race and religion impact on this group of families. The qualitative research is supported with a quantitative element, which is an analysis of wave 5 of the Millennium Cohort Study. This allowed for a comparison between BME and white children from survey data representative of the UK population to see their engagement with formal and informal sources of support. Today's presentation won't actually give me the opportunity to discuss the findings from the quant element, but that's something that I may come to in future. So the academic discourse and beliefs are very much around the fact that BME families do not access formal support because it's against their cultural beliefs, religion does not allow them, they have a greater resource of informal support through family and friends. This is reinforcing stereotypes of BME families, of them living in an extended family household with multiple generations under one roof, and it's homogenizing their needs and experiences. Some of these beliefs were, however, reinforced by interviews I undertook with practitioners for my research. So what were some of the findings? The findings from the qualitative interviews with the parent carers, I found that in terms of religion, in general, the interviews with the parent carers of BME children with life-limited conditions indicate that BME families face some similar challenges when caring for their child and family as those faced by white families. Religion and culture were definitely not found to be a barrier to use of formal services. So every parent carer was asked whether religion was a barrier, whether it prohibited them from taking up formal support services, and overwhelmingly their response was no, religion did not form a barrier. Not one family cited religion as a barrier to formal support. However, the interviews with professionals highlighted that there was a widely held belief amongst them that BME families were choosing not to access formal support and had no need for this service due to religious organisations providing that extra layer. Informal support was explored through qualitative interviews with parent carers. Though they identified family members as providing support, this tended to be emotional support rather than practical support. Their family networks were actually dispersed around the world. So when I would ask somebody, do you have family support? They would say, um, yes, my mum, she's really helpful. I can talk to her anytime. But it's only when I explored it further that I would find out that actually their mum is based in India and they talk through online platforms, amongst other things. So they may be able to provide a layer of emotional support. However, they were unable to provide practical support. They also, parent carers also identified that most family members did not have time because they also had their own families, work, responsibilities, and the lack of skills that they may have to provide specialist care for a child with complex support needs. Some family members lacked confidence to help to care for the child with a life-limiting condition, and some parents did not have confidence in informal carers being able to care for their child's complex needs. Informal support was an inadequate substitute for the trained staff support families could access or receive through formal services. Families expressed the need for formal support services to help with their caring roles. Those families accessing formal support overall found it extremely helpful, and they formed strong relationships with practitioners. They spoke particularly well of support they received from hospices, and it was really interesting to hear the language they used and how relieved they were to be able to go to a hospice and just to be able to relax and be together as a family, to enjoy that respite. They also gave accounts of consultants and health staff who went above and beyond their roles to ensure that the family received support as and when they needed, to the point where some consultants gave family members their personal number and they were available outside of office hours. So there's a kind of message there, implication that they may have felt that these families were so isolated and needed this extra help, which is why they may have made that taken that extra step. Also, 10 interviews were done with professionals working. Interviews came from a range of professional backgrounds: hospices, health service, social work, and schools. They included BME and white professionals. All participants came both from England and Wales, the parent carers and the professionals. Professionals were asked about their perceptions of the needs and experiences of BME families of children with life-limiting conditions. They were also asked to identify barriers that they may perceive to uptake of formal services and provide some insights into the experience of BME families who had engaged with their service. Two themes emerged from interviews with professionals which did not feature in the parent carer interviews, but could be a barrier to accessing formal supports. These were racial and ethnic stereotypes of BME families and stigma and blame directed towards this group of families. So, for example, Karen was one of the participants in the research. She referred to several common ethnic, racial stereotypes of BME families. She explained, this is a quote, well, for example, they, brackets colleagues and service providers, say families from BME communities want to provide all the support themselves. They have so many extended family that their needs are all met. Another stereotype is mother would like help, but father won't allow it. Karen said, it would be absurd to make that assumption apply to all families. It can't possibly. It's all very anecdotal. It may be true for some families, but there's a tendency for stereotypes to be created and then for people to say, oh, well, there's no point in referring them. The fact that we and other hospices have had families in proves that is absolutely not right. Mary, another professional I interviewed, spoke, quote, they're a closer community and a closer network, A lot of them have larger families and they will depend on family more. Their faith leader, if they have one, will probably already know about their situation and support them. I do think in BME communities they are closer. So again, it's that ethnic stereotype of BME families being communities being closer and family informal support. Maria said the following, quote, a lot of the BME families have very large networks. They're very close to their extended families. So as you can hear, there are still strong ethnic stereotypes. Interviews with the parent carers of BME children with life-limiting conditions demonstrated that BME families had support needs and valued the support offered by formal services, irrespective of whether or not they had family support. Informal support is not an adequate substitute for formal support and can be a gateway to further services and sources of support such as peer support, charitable grants for relevant disability equipment and family holidays. And formal support is much more reliable and may meet the needs of a family much better. So what are the recommendations for practice? Generalizations and assumptions based on ethnicity alone should be avoided. Each family is unique. Avoid ethnic stereotypes and assumptions. Adopt a person-centered approach to assessing the needs of each family. Ask the family what they would like. They are the experts of their situation. Families value this approach. One of the parents I interviewed, Chan's mother, she said, quote, just ask me. It's just basic respect. I'm not offended if you ask me. I'm offended if you assume things about me. Another parent, Hanif's father, stated, just because you have an Asian family, it doesn't mean they'll want Asian food. They may not. They may want English, you know. They have Asian food at home. They may want to change. So these are some of the things that we need to think about. But by attaching the BME label, we shouldn't other them to a point that we dehumanize and make assumptions. We should remember that this family is unique. Their needs will be specific to them. They are the experts of their situation. And most of the participants I interviewed were more than happy to be consulted about their religious, cultural, and linguistic needs. Ecological systems theory, ecomaps, and culturograms are useful theoretical and practical approaches and tools which can support assessing formal and informal support systems and collecting relevant data regarding ethnicity, religion, and culture. So one of the findings from one of the professionals was that people didn't feel confident and competent in addressing issues and assessing needs around ethnicity, religion, and culture. So tools such as culturograms are really helpful to explore that. Ecological systems theory helps explore informal support systems as well as formal support systems. So who is present in the family, and ecomaps is an excellent tool to help with that theory. Regular training and support should be offered to staff on working with ethnically diverse groups. Most of the participants I interviewed said that they didn't have and had not been offered that training, and if they had, when they had been offered it and undertaken it, they found it really helped and support their practice. However, what I noted was even though people said they would find it helpful, they hadn't actually asked for it. So it may be something that organisations may want to regularly offer rather than wait for it to be asked, because staff may be afraid of making themselves vulnerable or exposing their weaknesses in some way. So for whatever reason, it may be an option for an organisation to regularly offer this training. The interviews with BME staff stated that often when they were roped in to provide this training, it wasn't always appropriate because they themselves wanted to participate in the training, or that they had not had training, the trainer training themselves, and assumptions had been made about their knowledge and confidence and competence to deliver this training. They also spoke about how diversity training is quite a sensitive issue, and they didn't feel comfortable training their peers or having to challenge them for any reason. So they felt that they themselves would like to participate. They felt that a independent outside source coming in and providing that training was preferable. But in conclusion, ethnicity can impact on the caring experience of Black and minority ethnic parent carers of disabled children. Outdated stereotypes of ethnic groups persist in some formal support settings. There is a need to adopt a person-centered approach with each family. Assumptions cannot be made about the availability or need for formal or informal support based on a family's race, ethnicity, or religion. I hope you found that interesting, and I look forward to meeting you at the conference. Thank you.